I'd like to bring up Neil Segal, who is in our GI service and has been a real leader in developing immunotherapy for patients with colorectal cancer. And Neil will give us some updates on where we stand with that.
Mike, thanks for the introduction and for inviting me to present today. So I'll talk on colon cancer and immunotherapy, and I'm focusing this talk on microsatellite stable colon cancer because that's really where a lot of the research is being done and a lot of the need is currently. So the four topics that I'm going to talk about is, one is just outlining what is the need for developing novel therapies within colorectal cancer, metastatic colorectal cancer, what has not worked and why not. We don't know why not, but I'll put forward a couple of points and then focus on three emerging strategies. Current treatment for metastatic colorectal cancer depends on mutation subtype with RAS and RAF and sidedness, but essentially we have two combination therapies, two lines of therapy with FOLFOX, FOLFIRI, in combination with the biologic. In the United States, patients may get a third-line therapy with an anti-EGFR if they're appropriate. In Europe, it's an earlier line. And then following these 2 or 3 lines of therapy, what we really offer our patients are regorafenib or TAS1 and 2, which puts forward the idea of the bar that immunotherapy at least needs to meet, in order to find a place in third-line therapy. One of the drugs that we have is regorafenib, which is an orally administered multi-kinase inhibitor. And just bear this in mind because we're going to come back to regorafenib a little bit later in combination with immune therapy. And what this drug does is targets VEGFR 123 as well as several other targets, including PDGFR and BRAF. But essentially, this drug, although it met its endpoint in the clinical trials, which is why we have it as an option, has a response rate of only 1% and a survival benefit of 1.4 months at the expense of multiple toxicities. The other drug that we have in a similar setting is TAS102, which is another oral drug similar to a 5-FU type of drug, but it can work in 5-FU refractory patients. But here again, we're seeing a response rate of 1.6% and a survival benefit of 1.6 months, maybe a little bit easier to tolerate, but still at the expense of some toxicities. So there's very much a need for new therapies in colorectal cancer. Within the space of immunotherapy, many trials have been done over the years, and essentially what you're seeing here is a list of monotherapy studies using PD-1s or CTLA-4, and these have all really been negative studies. Occasionally there's been a responder. There are very, very few responders that we see in colorectal cancer, and for some of these patients we don't know what the MSI high status is. A more recent study was done looking at an anti-PD-L1 in combination with MEK inhibition. There was a lot of interest in MEK inhibition because there had been responses in microsatellite stable colon cancer in some of the earlier phase clinical trials, thinking that this might reverse some of the immune resistance with the T-cell exhaustion, as well as the regulating MHC and antigens, but this was a negative study. Right? There was an overlap in survival curves of anti-PD-L1 with a MEK inhibitor compared to, in this case, regorafenib. Again, low bar to beat, but still it didn't. But if you really take out the regorafenib, which is the blue line in the middle with survival, there might be some suggestion of perhaps at least a differing in the survival curves prior to them converging. So I don't think targeting MEK is completely out of the water, but this is certainly no home run. Why doesn't colorectal cancer respond to immunotherapy? This is not a low mutation burden tumor. Right? The mutation burdens are similar to other tumors that do respond to immunotherapy, so there's a lot more than just underlying immune targets. This essentially is a cold tumor with a paucity of immune cells, so a lot of the strategies that we do need to get the immune cells in there. We don't know why colorectal cancer is immune void. One of the suggestions has been because of APC, which is mutated in almost all colorectal cancers, a very high percentage. And as you know, APC is important in beta-catenin pathways, and APC traps beta-catenin with axin. And if you have a mutation in APC, this Wnt pathway can be activated. And there'll be a high amount of beta-catenins, which are then liberated because APC is not keeping it at bay. And high beta-catenin Wnt pathways leads to diverse pathways of immune suppression, which may be implicated within colorectal cancer. One of the other possibilities is mutations in part of the antigen-presenting machinery, all the way from Golgi apparatus, ER, proteasomes, and then MHC expression. And there's MHC loss has been implicated in some colorectal cancers, but this is certainly not, cannot account for the lack of response that we see in all the other tumors, because these are essentially rare events. So the next part I want to talk about is we know that there's a need in colon cancer. We know that immunotherapy has really stood out as not working as monotherapies, which has been very disappointing. And it's very clear that we need combination strategies to try and overcome this resistance, or to force these T cells, bring these T cells into the tumor and try and make that immune void tumor immune hot. And I'll talk about three of the strategies. The first one are natural killer cells, and there are lots of efforts have been targeting natural killer cells in many different settings. You just heard Laura talk about lirilumab, which targets NK cells. There are many strategies, many of which might seem to be interesting in the beginning, but somehow don't always remain that. But in colon cancer, we did a trial, and this trial started in our phase 1 ITC EDD clinic. Matt Hellman had spearheaded the development of this monalizumab, which targets NKG2A. So NKG2A is found on natural killer cells and T cells, binds to HLA-E on tumor cells, and it suppresses them. So like similar to what PD-1 would do, but different access. But if these NK cells or T cells interact with the tumor, they'll be turned off by NKG2A. And monalizumab binds to NKG2A, so it removes at least this one inhibitory mechanism. So the study was done of combining that with anti-PD-L1 durvalumab, and this was a typical dose escalation with an expansion that, as I said, Matt had led. But there were a significant number of colorectal cancer patients included, as well as a dedicated cohort. And although it's certainly no home run, right? We're looking for signals to guide the next study. What we saw here were 3 patients that responded, right? So if it's another tumor, that's not that exciting, but when it's colon cancer, it is. And these responses did occur, and some of them were deep responses, so certainly a negative study. But with an 8% response rate, recognizing just 3 patients, this was interesting and has led to future studies. Ongoing studies now will have durvalumab, monalizumab, and cetuximab, right? Cetuximab might recruit some of the NK cells into the tumor, and we're going to see if we can further activate them, or in combination with chemotherapy. And these are ongoing studies that we're running here and following closely. The next study, this was reported recently at ASCO by a Japanese group, combining regorafenib plus nivolumab. So earlier we know that regorafenib by itself is not doing much, and this was a dose escalation study in gastric cancer and colorectal cancer with different doses of regorafenib from 80 to 120 to 160 in combination with nivolumab, followed by an expansion cohort with the primary objective of DLT MTD and recommended phase 2 dosing. The study told us that the recommended dose of regorafenib is 120. The maximum dose we use in clinic, or we used to use in clinic, is 160. It's a very difficult dose of regorafenib to give. It's a very tough drug, and there's even more recent data to show that we can start with the lower doses, and this study just reinforces that the high dose of regorafenib is really not tolerated. So it gave us an MTD that went forward, and in terms of efficacy, very unexpectedly, drugs that we had available in the clinic all this time, and very excitingly, showed us a response rate both in gastric cancer as well as colorectal cancer. And although a limited number of patients, it's not a very small trial, but it's certainly not a large trial, but it showed us a response rate of 33% in microsatellite stable colon cancers. There was one MSI high tumor with the diamond, so we won't look at that because that could have responded to the nivo. And then in the top right-hand corner, you can see an example of that these are, at least in this patient, real responses with the reduction in 2 lung metastases. So this has led to a lot of excitement of the combination of regorafenib plus immune checkpoint blockade. And there was also a PFS benefit here of 6.3 months. Regorafenib alone would have a PFS more like 1 or 2 months. The other point that came out of the study is when they looked at the doses across all the patients with colon cancer or gastric cancer, and what what this busy graph is showing, the diamonds refer to different doses of the regorafenib. But if you look at the bottom, the last line, the response rate was 45% in the lower dose regorafenib group of 80%, 36% response rate if regorafenib was slightly higher, and a 33% response rate if regorafenib went to the dose that we previously used in clinic. And what this showed us is that even if we look at the MTD of 120, but we can go lower than that to a dose of 80 milligrams, the response rate is not compromised. And this was the dose of regorafenib that was selected in the expansion cohort. So this, to me, is very interesting data, the fact that regorafenib in combination, and we are seeing this outside of only regorafenib, but other multi-targeted TKIs like lenvatinib. Laura also had mentioned that, which has shown efficacy, early efficacy in several different types of tumors. So there's more than one drug that is a multi-target TKI that is in combination with immunotherapy effective. The understanding of why this happens is unclear, but in this study they did show a depletion of Tregs in the few patients that they looked at. If you look at the PRs versus the stable disease. So perhaps it's a Treg targeting, but there may be several other targets that are also coming into play. The third drug that I'm going to talk about is the sebisatinib, which is a bispecific antibody of CA and CD3. And what this drug does is binds to CA on the surface of tumors. It shouldn't bind to CA on the normal bowel based on its affinity, as well as to CD3 cells. And it's going to bring in T cells, which you see there in green, are going to bind to the tumor. And these are non-specific T cells, so they're not, because they're just being tethered by the CD3 and not the T cell receptors. They could be a T cell that's looking for the flu virus. They just happen to be close to the tumor. They get tethered and stuck. And as we know, T cells don't like being tethered and stuck, especially by their CD3, and they'll start to attack whatever's closest. And in this case, it's the tumor. They will then disengage and move on to another tumor cell. So there's serial tumor killing. So the rationale for this was based on this rationale, which was pretty interesting in early mouse studies. When we took this into patients, so far what's been reported are just the initial patients, and we have toxicity on the first 80 or so patients. There was a monotherapy study of a bispecific antibody by itself, as well as in combination with an anti-PD-L1. And the types of side effects that we see here relate to cytokine release, to tumor flaring, and with diarrhea, pyrexia. So initial patients are required to be in the hospital for their first dose. Will undergo a lot of these cytokine release symptoms, similar to what you would see within a CAR T cell. So I think about bispecific antibodies similar to CAR T cells in terms of the way they're working, like getting T cells to engage and get stuck, as well as the type of cytokine release. In terms of efficacy, this is an example of a patient that we treated here with microsatellite stable colon cancer. And you can see a reduction in lung metastases based on the PET scan, as well as the CT scan, which was very exciting to see as a proof that this type of strategy might work. This is a plot showing tumor shrinkage. On the top, you see the dose escalation of the bispecific antibody. Blue is the lower doses, and the orange-brown colors are the higher doses. So at the higher doses, there seem to be higher tumor shrinkage, not necessarily meeting criteria for response, but at least some tumor shrinkage. The question of durability still needs to be addressed, but the fact that there is early efficacy. And what was reported so far, although many more patients have been treated since then, but this is only what's been published, are the first 11 patients, and which showed a partial response rate of 18% if patients got combination therapy, as opposed to 6% if they got monotherapy. So this is the high doses and in microsatellite stable colon cancers. This drug is currently in further clinical development with an expanded trial. So in summary, although I didn't talk about MSI high tumors, we know that MSI high colon cancers respond. So there are two different types of colon cancer when it comes to immunotherapy. The first are the MSI high, which respond, and then the microsatellite stable, for reasons of biology, have typically remained immune void or precluded despite a sufficient mutation burden and the challenges to overcome this. And we need future rational combination strategies, including NK cell targeted therapies to be developed. We need to look at these TKI combination therapies, which is happening with regorafenib as well as others, and then further develop bispecific antibodies and other types of drugs like that. But we are reassured that sebisatinib The first bispecific to show emerging efficacy in solid tumors, as well as clinical benefit in an early study in patients with colon cancer, but we need a lot more data and we need current studies to read out. Thank you.
We have a second if anyone has a burning question. Otherwise, in the interest of time, I think we may move to discuss some questions in the panel, if that's okay.